Good afternoon, everyone. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And Lieutenant Jeff Bussey.
Hey, Chief.
Thanks for joining us, Jeff.
Sure.
So today we're going to talk about a case that was an agitated patient that was secondary to a structure fire. Sounds like you were on Rescue 15 and you guys were assigned to a 69 Delta. So that's obviously your primary response on that one is you're going to the fire. Talk through how you ended up encountering this patient once you guys started your fire operations.
So when we got on scene, we were notified that the individual, the occupant of that apartment, was outside and was injured, was bleeding quite a bit. So we were kind of assigned to patient services. We went up to try to make contact with this person. He was covered in quite a bit of blood. He had a big, kitchen towel wrapped around his hand. But he was very agitated. He wouldn't listen to any of our commands, wouldn't answer any questions. He kept trying to go back into his apartment, which was the fire apartment, kept trying to go into another apartment. Neighbors kind of told us that he was a known meth user, and he'd been having some hallucinations going on pretty recently. So every time we talked to him, we tried to get him to come out so we could assess him, and he would kind of get halfway out the door and then go back in, halfway out the door, go back in, just very agitated. He said he was bleeding quite a bit, so there was blood all over the scene, his apartment, the sidewalks, and it was kind of creating more problems for the engine crews that were trying to do fire attack. So,
and how were you able to finally de-escalate him verbally to get him to agree to come do an assessment, or did you never reach that point and you knew you had to act in order to check on him?
So we had tried several times with 7-8, Rob LaReese was with us there, tried several times to get him to come out, and he would start to come out and then change his mind. And eventually we decided we were going to have to probably sedate him because he was not cooperating at all. So went back to the truck, drew up some Droperidol. And so the engine crew, along with the 7-8, they were kind of able to distract him enough that we could kind of sneak up on him and give him some IM, Droperidol, because he wasn't going to allow us to assess him anyway.
Sure. Yeah, we talked about how some patients, they'll require that chemical sedation before we can even appropriately care for them. So that's a great job of kind of talking with them, seeing if you can kind of distract them for a little bit. It's not what we always want to do, but sometimes it's necessary. So you guys did a great job of doing that.
And he was just creating, making it more difficult for fire crews because they were not only trying to get into to do, their job, suppression, but they were having to deal with him as well. So,
and he clearly had a life threat as well. He was bleeding all over the place, and
we didn't know where it was coming. We knew it was coming from his hand, but
blood.
we weren't able to actually visualize the wound, so we didn't know how bad he was wounded. But there was a significant amount of blood all over the scene.
So with the life threat, the danger to others, very reasonable to give him some medicine to help him calm down so you could do your job and help him.
Absolutely. So you administer the Droperidol. Kind of talk us through how long did it take? What did you see? Because I know it's obviously a new medication for us, and we'll talk about that a little bit. But what were the effects that you saw after you gave the med?
So, like I said, we gave the med and we just kind of stepped back. It took a good almost 10 minutes before he was able to just kind of calm down. It didn't sedate him. It just made him just mellow. At that point, when he seemed mellow enough that he would, cooperate and kind of answer our questions, then we were able to kind of re-approach him, but we had just gave the med and we all kind of backed off. And he kind of walked around a little bit. Finally, he sat down on the steps and we just kind of monitored him from a safe distance. And then when it finally felt right, we went up and were able to assess him then. Okay.
Talk through that physical assessment. What did you guys find in terms of his vital signs and how he presented medically?
So the wound he had was a laceration to his hand. It wasn't a horrible wound, but it was a full thickness wound that needed to be treated. His heart rate was pretty elevated. Vital signs were all elevated, pretty typical of somebody on meth. I've been doing this a long time, so we kind of know what that looks like. But
And Droperidol's new for us. We talked about it's a special skill that was approved by the Medical Direction Committee. So all those calls are 100% QA'd. Not everyone's had an opportunity to use it yet. How did you go about figuring out your dosing that was appropriate for the patient? Was it just review the protocols? Did you look at the BSI scales and talk us through what you were thinking on how much to give?
Yeah, it's exactly what we did. So we knew we weren't in a super rush to give it, so we had enough time to pull out the protocols, review them. Seven and I kind of talked it over. I had a basic drive-in for me that day, so I went. Rob and I sat down and talked. I didn't have anyone else to kind of brainstorm with on that one. So looked at the scale, and we were able to determine that 5 seemed like it would be appropriate.
About a 5 sounds about a 5. Yeah.
And Doc, I'll cut over to you. As far as with the Droperidol, it's an antipsychotic med. We know that. It's one of our new options. Can we mix that with other drugs if we needed to?
If needed, absolutely. The things I like about Droperidol, I'm glad to see you using it and trying it. There's good evidence that it has less airway compromise and acts about the same time as Versed. I think anecdotally what we're seeing here is maybe a little bit longer, but still very effective. If we have waited the allotted amount of time after we've administered it IM, it's okay to mix with Versed. Okay. They actually work really well together, sometimes kind of synergistically. I tend to like Droperidol for our patients that look like they're having more of a psychotic episode where there's hallucinations or delusions or maybe meth intoxications. It works really well for psychotic episodes, I think.
So you're able to get some vital signs on the patient, kind of reviewing your chart. You had a heart rate of 133. This is after you had the opportunity to assess him. BP was still good, 132/99, breathing about 28 times a minute. Sugar was good. Based on that special skill and kind of what you know of Droperidol, what other steps did you take following the administration after you realized he was otherwise pretty stable?
So once he was able to calm down and we were able to talk to him, we were able to get a 12 lead on him, just get the EKG and take a look at that, make sure that there wasn't any kind of abnormalities in there.
Perfect. And that was part of our special skill that you talked about, that when we do give it, then we have to do a 12 lead right after. What are we looking for, Doc? What do we want to see?
So we're specifically concerned about the QT. For the long time, Droperidol was taken off the market because there was some concerns that it could put patients into torsades. Over time, that's proven to not necessarily be true, but we still monitor for it just because there's that concern out there that it can prolong the QT. So in patients when we've had to sedate them and we've chosen to use Droperidol, if they're sedated enough to where we can get a good EKG, then we want to get that and just check that QT to make sure that it's not getting dangerously long. So far, we've been using this medication in our system for several months now, and I look at every one of them, I have yet to see anything even close to 500 on the QTC. So it's very safe for us so far.
And you had mentioned that they can also benefit from having a bolus secondary to the administration.
Absolutely. Yeah, these patients with that are in a severe state of agitation, this guy just got pulled from a fire, he's tachycardic, they've been working very hard, and so there's a lot of insensible fluid loss that can go with that level of agitation and sympathetic overdrive, and so a fluid bolus can sometimes go a long way. So get an IV if they're calm enough and you can safely do that and give them some fluid.
And Jeff, between your assessment of the patient, what helped you guys differentiate that this probably was some sort of behavioral health or psychotic episode, as opposed to being, in that fire and inhaling the smoke and being acting inappropriately because of that? Was there anything that you saw or didn't see that helped you guide your decision towards the Droperidol?
I think it was based on kind of what we were hearing on scene. He was stating that people were trying to get into his house and get after him. And then the neighbors were kind of, pulling us aside, saying that this wasn't the first time this has happened with this individual. He had been known to kind of act out, and they knew that he was a pretty regular meth user, and he'd made accusations like that before, that people were trying to break into his home. So it kind of led us to believe that this might be another one of those situations.
Gotcha. You guys did a fantastic job. This is one of those calls where you change gears multiple times. You go into a structure fire, then realize you have a patient, but then you have a patient you can't treat immediately, so you have to switch gears multiple times. I think you guys did a fantastic job all the way around. Anything that you would share with some of the newer officers or officers who haven't experienced this yet, as far as how to handle these types of calls?
I think maybe just go to it early. I think with my mindset was just the safety that of our other crews that were there. I mean, they're trying to do their job, and they don't need to be dealing with a psychotic patient that's making their job harder. So if we can give that drug early and get them sedated and get it's just that scene safety, get them under control sooner than later. I think that's probably a good thing.
Awesome. Well, great job once again to you and the crew. Thank you for taking the time to talk with us today. Thank you, Doc. That's it for today's case study. If anybody has any more cases they'd like to come in and discuss, reach out to us either via SharePoint on the EMS tab, or you can contact 7-8. Until the next time, we'll see you. Thanks.